Welcome to Health Stealth Radio, where we move away from the mundane to gather insights from the shadows of enterprise and patient cybersecurity. Yes, we surely believe that traditional themes like endpoint software and zero trust are critical, but given massive advances in AI, remote and wearable device hacking, and data hostage negotiators, there's a much darker side to cybersecurity, and not everyone is quite willing to talk about it in public. Health Stealth Radio will thrive on these topics and encourage fireside spats to debate them. Here's your host, Frank Cutitta.
Hello, everyone. My name is Frank Cutitta, host of Health Stealth Radio, a part of the Chime and Digital Health Insights product line and content. I'm thrilled to have as part of our program today Anthony Murray, who is, I'll let him describe his title, but one of his responsibilities is a Chief Interoperability Officer at MRO. And I'm especially happy to have Anthony today because I know he's a Philly guy, and it's always great to have a Philly guest. We in Philly always never looked at March Madness. We always looked at the final, the Big Five championships as our sport down there in basketball. So I'm happy to have him here and discuss some of the things that are happening. Another March Madness that we all just went through, or February Madness, is that we went through the healthcare trade show fanaticism that we have every year, and the shows seem to get closer and closer. It's bad news for those who don't really like to travel to Las Vegas or to other places. It's good news because you get a full dose of what's happening in healthcare all at one time. So I'd like to first welcome Anthony and have him give a brief description of his job and his title and what a day in the life of Anthony is like before we move into some of the critical issues that are happening in his segment.
Well, Frank, first off, it's a pleasure being here today. It's wonderful to see you again. Excited for the conversation. Philly basketball team's not looking great for the NCAA tournament. So, that bracket's looking a little empty. Still basking in a little bit of the Philadelphia Eagles glow, though. So,
Here.
I can't complain too much. Anthony Murray, like he said, Chief Interoperability Officer for MRO. I've been in release of information, disclosure management, and clinical data exchange probably for about the last 17 years, 25 plus years in healthcare. And my day in the life these days is looking at opportunities to continue to help primarily our provider clients drive real efficiency, privacy, and data security into their workflows where they have to disclose and share healthcare information for a variety of reasons. And how do we do that in a safe and secure fashion when we're exchanging information more fluidly and more dynamically and more digitally with less human intervention for something that's an incredibly complex and exception-based ecosystem and infrastructure like healthcare?
That's great. So one of the reasons we wanted to talk this topic of TEFCA, I had in a previous life the ability to launch the international editions of the Dummies series at IDG. So in a Dummies parlance, and Dummies are cool, so that's why we sold a lot of books there. In a Dummies parlance, could you sort of explain what that is and why it's starting to come to the fore at these conferences where you really didn't hear a whole lot about it unless you were running in the circles of information system security officers?
TEFCA, as we know, was really created out of the government's influence. Some may say that they were a little tired of the HIEs, HINs not really progressing for our ability to share information, mostly for purposes outside of treatment. So is there really an adoption of those technologies? Are we seeing the existing ways that we're sharing communication kind of bear fruit? So they decided to give us a little nudge. What you're seeing is that nudge took advantage of it, those levers, and they really started to put Sequoia Group as the RCE out in front of trying to bring this vision to life. And I thought Sequoia's done a really good job of being connected to that internal ecosystem that you talked about, people who are really doing clinical data exchange at scale for a long period of time. and working through the complexities of birthing this new exchange into existence and trying to take a lot of the lessons learned from those prior exchanges and bring more modern concepts to it, for ways that we can share more effectively, more securely, and really opening that door for additional possibilities for sharing outside of the initial exchange purpose. So you start to see momentum grow, you start to see some life get breathed into it and creating some initial of the SOPs. There was a lot of evangelism. And then you started to see adopters start to take place. So you started people thinking about how they were going to participate in this now that it had some legs. So as we went through the early adoption of the QHINs and getting them established and seeing who those players were, I think that drove a lot of momentum towards the forefront. And then obviously that focus of conversation is going to follow.
So how would you characterize the buzz at HIMSS and at Vive? And I know that you participated in some focus groups at these events. What are you hearing about it? And in the spirit of fireside spats or bickering, I mean, is there controversy related to this?
Well, I think let's start with the Vive CIO forum. So we went in with the intention of trying to like gauge the temperature on whether people were talking about interoperability in general is still a hot topic button. And it did not seem to be. So as like an interoperability lead, I'm like, well, what are we talking about then? So everybody's attention at that level has really shifted to cyber and AI.
So you're talking about sort of generic interoperability, like
Generic interoperability.
Okay, because as opposed to the integrated interoperability, which ties in with the other hotspots, right. I would imagine.
And then talking to them about like, are they still paying attention to it? How are they thinking about it? Primarily around TEFCA. So as we know, one of the key players is an EMR. We've got a couple of other EHRs that are now signing up to be QHINs or are QHINs. And how are you approaching QHIN selection? Are you thinking about TEFCA as something you need to participate in? And where are you engaged with following the progression of your EHRs that are now going to guide you through this path? And what we saw is they're not really paying attention to it. They don't really understand the trickle-down effects. There is limited understanding of the fact that TEFCA goes above and beyond treatment. And once you've adopted in or accepted into the TEFCA program for exchanging information, you're obligated to now exchange for anything that's required. And if we think about timing of those things, in January 2026, the way the SOP is written today, there's 3 other exchange purposes that are going to be brought to life that you're required to respond to. Are you ready for it? Are you thinking about it? Are the people that you're signed up for your QHIN services having conversations on how you're going to meet those obligations? And it wasn't that impactful. I had a couple of people grab me after the session and they said, wow, I think the point of what you just said is we're not talking about this, but we really should be. And that struck home. So in theory, they were taking that back to their organizations to try and put together a strategy around the changes that TEFCA is bringing forward.
How do the people like the word obligated?
I think they felt a little bit of pressure that they didn't understand before, that they immediately felt behind. And I think this is where people fall back onto, well, my EHR will figure it out. So we'll just worry about them and the obligations.
Interesting.
We'll see how it goes.
It's interesting you raise the point about interoperability sort of not being at the premier level that it used to be for many years. But to your point, though, it did come in. I think when I first met you, there were 2 things that I've gotten, not from only from this conference, but from a previous conference. One is that interoperability is not a technology issue to a large extent. And number 2, the one that I did get from Vive was somebody who said, warning, 80% of your artificial intelligence isn't going to work because of fill in the blank interoperability challenges. So how do you, I mean, obviously, I think the first one is not even arguable that there is a human factor. I don't want to share stuff. And so that happens not only with interoperability, but in my business with marketing databases, the events people don't like to share with the advertising people. So how would you react to the intersection of artificial intelligence and interoperability? And we'll get into AI a little bit more. where somebody would claim on the vendor side that 80% of the things aren't going to work because of interoperability.
Yeah, I don't know where that number came from, but and I also don't know that don't work is the right way to think about it, but AI isn't magic. We already know that it has its warts and faults, and we understand that it takes large sets of data. If we're talking about like the large language models and the generative AI, it takes a lot of information in order to train those models. So access
Maybe
to
exaggerated.
information is critical in order to begin to really train your models. The access to the data and the information is the key for what interoperability brings. And if we're not able to even like correctly solve for the simplest use cases to get out the basics, and like if we go into like what's available through Fire, how are you getting things through your ADT messages, where is all this information coming from, how discrete can it be boiled down, and can we pull it in a way that we can start to train models against, or how do we get the models to help us break apart unstructured data and turn it into structured information that we can actually like utilize for a variety of purposes. So yeah, I think a lot of those things do intersect. My role is to help open up and tap into ways that we can access data that you can then apply AI to. And AI is just changing so fast that to say that it can't absolutely like solve problems, I don't know that I'm going to decide on for that. But I don't think it's as easy or as fast as everybody wants it to be. And I think we're in a little bit of still the hype cycle around AI.
No, totally agree. One of the things that did come up in all the conferences, and it comes up without even going to a conference, is that the governance is sort of cool again. It used to be that I'm going to call in sick the week that they have the governance meeting. And now, I mean, obviously AI governance is huge. Cybersecurity governance is huge. And all of these things intersect with interoperability, and I'm sure with TEFCA to a certain extent. Who are you seeing in terms of governance? Who are the collaborative people that in your profession that you're working with? Has the complexity and the diversity of the people that are working on these things changed because of things like interoperability aspects of AI and cybersecurity?
Yeah, so I think it's an interesting question. I think where we see the most engagement is relatively new. The CIOs get interested when you start talking about AI. We see more engagement with the chief medical officers than we had in the past, which again in our market is a relatively newer experience and much bigger hand in solving things outside of our normal space. So looking more closely with like rev cycle and solving some of those things that really take a lot of human interaction in order to deal with. So are we making advancements in coding? Can we do things like abstracting? That's really brought a whole other swell of people to the table, and as well as your security officers, your compliance officers, and your privacy officer, who are normally people that we would deal with, and the pure technologists that are like standing up your interfaces.
So, considering the workforce as it is right now, or it isn't, depending on which healthcare system you're working for, what are some of the challenges that organizations could expect in terms of implementing this kind of technology or this kind of strategy, and who do they have to bring in order to make sure it's successful?
Again, if we're leaning kind of back on TEFCA, they have most of the interfaces built for their existing HIEs. Depending on how you're doing that today, that might be an easy lift and replace for the use cases that they've got for treatment to carry over into a TEFCA type model. It's really all of the secondary contractual things on the must responds, the should responds. Are people looking at the contracts to understand their obligations? And do they have the necessary infrastructure internally to actually support those? If we think about coming up in January of 2026, again, as an example, HEDIS, quality reporting for non-HEDIS purposes, and case management, I think are the three. How much of an investment does the provider organization need to make to A, ensure that they're able to respond to those things that they're required to, B, go build the templates in a way that they're satisfied that they're honoring concepts like minimum necessary, privacy? Are they allowing for sensitive information to slip out? That's all diligence that a provider really should be doing, regardless of who they pick for a QHIN,
Sure.
how they decided to implement those things. So what are the resources that they have to have lined up? What are the controls that they need to now have in place? What does the roadmap look like? And are they future proofing that work into where they're investing from a people perspective?
Mm-hmm.
So I think those are a lot of the key challenges. Are you keeping up with how dynamic the market is? Are you keeping up with how quickly the changes in these SOPs and these exchange purposes are happening? And are you building that into how you're planning your data sharing profiles? How do the new XPs have impact beyond just sharing information? Are you talking to your rev cycle? Are you talking to your value-based care teams? As we move into more advanced exchange purposes, does it have a broader impact on your organization? And do you have the right people to even assess that?
So when you bring up the contracts, you're talking about the contracts with organizations like MRO?
Well, with the QHINs and
with the QHINs. Okay. Because one of the things that it becomes very interesting in some of the discussions and interviews we have is the evolution of the service level agreement that providers are having with organizations like your own and other organizations, that they're migrating to sort of a performance and safety based model as opposed to just keeping the lights off and on like we used to have in the telecommunications market. Are you seeing that some of those service level agreements are migrating to meet these new protocols?
So we haven't seen it directly in that way. Our relationship with our provider customers certainly can get impacted by some of those decisions. So we have to be thoughtful about how we approach some of those conversations. And we are forward and transparent with our providers that say, if you do this, here's the impact for our organization. But we haven't had any additional performance level metrics laid upon us because of some of these changes.
Understand. So as we start getting into the QHIN thing, I want to avoid the alphabet soup and just have you, first of all, going back to our dummy series, define exactly what that is, and then maybe talk about some of the factors that CIOs should know in terms of evaluating and joining and deploying these QHINs.
Sure. So we'll go to the Wayback Machine. So a QHIN is a Qualified Health Information Network, and that simply means an organization that has implemented and proven the capacity to run the technology required and enforce the security and contractual agreements required, meaning they show the necessary capabilities to deliver on all of the use cases that, in theory, TEFCA has already announced will eventually be part of information that they can share. So it starts with individual access and treatment, and then rolls into a variety of other use cases, including operations, possibly payment, and there's a fixed list out there. And TEFCA is the Trusted Exchange framework and the Common Agreement. So that's simply a way that people who want to participate in it are obligated to implement the necessary technology and have the appropriate contract language in order to protect what we would think of as confidentiality, integrity of these transactions. So all of the concepts are great. There is a little bit of a contractual burden that's put on it through these. So how do you manage with that? How do you negotiate all of those nuances? Because there's all of the trickle-down effects that come into this participation that don't exist prior to TEFCA. So if we think about like how do we do selection based off of the opportunity, because TEFCA is voluntary and it's supposed to be that way. Like you can choose to participate in that network. You can also choose who your QHIN is, so that you have the ability to select who's representing you on that network. As a provider organization, your easiest reaction would be, well, I'll follow my EMR, EHR, and that might be a good selection for you to do. But at the end of the day, you need to look at the values of the people that you're beginning to engage with, understand, do they have additional benefits for you and your organization? What are you trying to get out of joining these types of networks? Are you looking at it because you're trying to advance healthcare? Are you looking at it because you're trying to offset human labor and be able to just share more electronically and focus on things like actual treatment of patients? But you want to find a partner, whether it's your EHR or not, that helps you drive your vision for your organization and brings the most value to you.
It all seems quite logical to do it, but what are some of the major areas of resistance that you see when you're working with clients on deploying these standards?
Yeah, so what I would say is for the adoption of TEFCA, we've seen that there is, you asked earlier, and I'll kind of circle back to, is like, what's the buzz been around with the QHINs and TEFCA? Well, there was tremendous optimism around this, and there was a huge breath, and everybody kind of like jumped in with both feet. We saw the first 6 or 7 QHINs kind of get stood up, pretty quickly, and then the work really starts. So I think some of the hype cycle around it has started to dilute a little bit, and we're kind of into that hard work cycle of what's happening there. The challenges of implementation are people really committed to it? There's a little bit of ambiguity there with the change of the government over. So what's really going to happen to it? We're in a little bit of a lull right now as that's happening, and all of the things kind of sort through from where is ONC going to land now that it's ASTP ONC? Is it still going to be a focus for this administration? And if not, do we kind of like wait and see, and are we going to go invest in this right this very moment? Or is it going to come out the other side and then we're going to be doubling down trying to get this rolled out very quickly? So I think where you invest, when you invest, has been a big part of it. And then that whole other level of you are now required to do more than you were doing, and do you have the appetite to go do that?
How paralyzed would you say that some of the providers are right now because of the policy area in Washington in terms of pulling the trigger on some of these things?
From what I've seen and heard, most of them are in a wait and see. And if we look at the volume of where information is still being exchanged, primarily it's on the existing exchanges, and we know that care quality and the QHINs are still kind of split. So people who have opted into like an organization like Epic, their information is actually transiting. In theory, they're split, but we see all of that volume really still happening over care quality, and not a whole lot of it happening over TEFCA right now.
So what do you see the risks as being if somebody sort of drags their feet on this and doesn't start doing it rather quickly?
That if you said yes and you're not prepared to support these other things that you're required to, that you're now behind. And there's a chance that you're letting information go out of your organization that you weren't ready for, either from a governance perspective, like you said, like governance is a big deal again. And then, do you have any ability to influence what is actually being shared, or because you followed your EMR, your EHR, your existing QHIN, that they've actually dictated how they're going to shape the information coming out of your organization? I think those are really kind of the biggies.
I'm sure a company like your own, as many other companies, want to work with the big guys, the Cleveland Clinics, the Mayo, and so how do you see smaller providers, rural providers, getting involved in this? Is this really scary for them just because of resource issues?
No, I don't know that it's scary. I don't know that they're thinking about it. And I think where we've got concepts like Community Connect or the shared instances, that they're probably following a lot of that same model, which is I'll go where my hosted EHR is going. I think when we think about those longer tail and those specialty practices,
right?
I don't know what their plans are, because those like Onco EMRs, the other ones are not QHINs. So are they having those conversations because they're ready to expand it, or are they happy with what they're doing from a localized exchange perspective because they're so embedded into their regional HIEs where they're getting a lot of value out of sharing that information today, and they don't see the necessity to go chase after something that could be a TEFCA.
So just to add sort of a closing remark or a pay political announcement, maybe in terms of MRO, what do you see is an organization? What advantage would an organization have by using your services, and how many of them just say, "Well, I could just do this on my own"? And what are the perils of doing it on your own without the help of an organization like your own?
So it's an interesting point, at least on the end. Why I would say that there's an advantage for us is because if you're not interested in just following a certain pathway that's being driven by your EMR, your EHR, your QHIN, we can give alternatives that solve a lot of those same things. Okay. We are creating digital ways in order to share complex information that have high value and allow the provider to be part of that process through direct engagement in creating all of the controls that are necessary in order to release it. Being able to turn it on, turn it off, having complete visibility to that exchange of information that's happening, whether it's digital or manual. I'm not dissing anybody's platforms or whatever, but I don't know that providers are taking the time out to go look at some of the reporting that's available to them if it's not line of sight for their productivity in a day-to-day thing. So I imagine there's a lot of things transiting their network that they're not actually going back. And how much information for patients have we shared on care quality this month? As TEFCA rolls out, like, are we sharing for additional use cases? Even like the direct connections to some of the EMRs, I don't know, give granularity to things like purpose of use the way that I think all providers are satisfied with.
Right. That was great. Well, my engineer's giving me the signal here. We've reached the time limit for our program. I'd really like to thank you for joining us. Thank you for your patience in terms of not being able to get together at 5 and reconvening here today. And I'd like to thank our audience for joining Health Stealth Radio and joining our episode today and the upcoming episodes this month. Thank you again, everyone. Thank you, Anthony.
Thank you, Frank.
Thank you for joining us today in the shadows for this episode of Health Stealth Radio with Frank Cutitta. If you like the program, please be sure to share your comments on our social media sites, or feel free to contact us with suggestions for new and stealthy show themes. We look forward to welcoming you again for our next broadcast. In the meantime, stay safe out there.